Bismillah. Today my case will be I'll give the title Desert Ulcer, and it's one of the miscellaneous cases, and it will be, inshallah, very informative and very miscellaneous indeed. So today our story, it's about a GP who was working in a small clinic in the desert outside of Baghdad in Iraq, who was consulted by a 26-year-old man. He presented with a slowly enlarging painless lesion on his face that started a few weeks after an insect bite. So in such cases, okay, we're talking here about skin, talking about insects, desert, all these together. What systems usually come to mind in the beginning? How am I supposed to read? The systems we think about most of the time, first of all, of course, infectious because of the insect bite and the onset. And then also we will be thinking about dermatological since it will be skin related, and it will be atypical, could be inflammatory, could be cancerous, and that will be further investigated through thorough history as well as thorough physical exam. So differentials, as I said, infectious could be impetigo, could be cellulitis and abscess. Dermatologic could be contact dermatitis, reaction to an insect bite. It could be any insect bite and just reacted to it. It could be possibly neoplastic. The basal cell carcinoma, squamous cell carcinoma, because it's on the face, and the guy lives in the desert, sun-exposed areas. It's possible, plausible, and feasible for the person to develop cancer. So among these, what would be the ones that you would like to rule out first? So, of course, the ones that you'll be ruling out first will be inflammatory as well as neoplastic. The utmost importance will be neoplastic. So as the history unfolds and we take more details, the patient presented with a lesion on his face. It's like a small red bump, okay? And then the lesion developed over a period of 3 weeks after an insect bite and became gradually larger, and it's painless the whole time. It hasn't healed, and then it eventually developed into an ulcer. The patient denied fever, okay, denied discharge, which helps us rule out a little bit infectious, like impetigo, cellulitis, abscess, recent trauma, similar lesions in the past. It's pretty much ruled out. So, in a case of a chronic, painless nature of lesion, what are the differentials that we think of mostly and less likely? So, less likely it will be infectious. Infectious will probably be something acute. Something inflammatory will be acute. It wouldn't be an, a little bit subacute or chronic process. And instead, we will think about something like atypical infection. Could be TB, could be syphilis, could be leishmania, could be any ulcer forming infection. So as for the past and social history, one thing that we that's eye-catching in this case that the person works in a rural desert area near Baghdad, and he works outdoors most of the day, and he noticed that there's a lot of insects in the area, especially around at night. So in this case, you'll be thinking of an organism or a route of transmission. So insects could be a key for a route of transmission. And usually insects, they carry around different types of diseases, malaria, um, they carry malaria, they carry trypanosoma, they carry leishmania, a lot of other different diseases. And we could be thinking one, especially a specific vector or an insect that is famous around in the deserts of the Middle East. So what will we do after we gather the information and history? Certainly, we will examine the patient. And what signs are we specifically looking for? Since the patient's lesion is on the face, we'll be looking for lymph nodes in the head and neck area. We will be looking at the ear, nose, and throat thoroughly. And we will meticulously examine the ulcer itself. The edges, is it well circumscribed? Is it poorly circumscribed? The location itself, the size, the shape, um, is there any discharge? All these will be examined on the ulcer. So a picture of the presentation will probably be something like the one in the slide. So you'll be assessing the general appearance. Is he systematically unwell? Is he feverish? Is he nauseous? Is he um, having any sort of malaise, um, uh, an acute distress? And then you'll be looking at the side, the shape, the borders of the ulcer itself, and the surrounding arrhythmia. If there is any secondary infection, for example, in the ears, in the nose, in the throat, maybe otitis, maybe conjunctivitis, maybe sinusitis, palpable lymph nodes. The lesion itself, is it hard? Is it tender? Is it non-tender? This helps us differentiate it between inflammatory, infectious, and non-infectious, like cancerous. And then you'll be looking for additional skin lesions. Maybe he'll having similar ulcer somewhere else in his legs, in his arms, in his torso, and you'll be thoroughly examining it all. So, what characteristics usually suggest a chronic infectious process? The fact that it hasn't healed and that it is indurated erythematous, and the lesion itself, that what's important from the history, that it's non-tender on examination and history, it's painless, and it is slowly growing. And this we need to inspect. For example, whenever we want to inspect a mass, first of all, eyes first, and then hands next. And that's usually how we approach skin lesions or masses. So labs, since most of the dermatologic disorders are clinical, labs will only help us rule out other causes, and it will help us narrowing it down to the main disease or what's the clinical presentation. So the CBC was within normal limits, the CRP is normal, urine electrolytes, all systematic laboratory investigations were normal. So for a skin lesion, what investigations will we order next? And how can we confirm? So the things we opt for in such cases will be skin lesion smear or a skin biopsy. And then we will be examining it under a microscope. And the definitive diagnosis will require demonstrating the parasite in the tissue. So after skin biopsy was done, the microscopy showed intracellular and mastigoids, Leishman Donovan bodies within macrophages, and this finding is diagnostic for cutaneous leishmaniasis. So this disease that the patient presented with is called cutaneous leishmaniasis, also known as Baghdad boil, أو بالعربي حبة بغداد. It is also known in Syria as حبة حلب, Aleppo boil, and as well as in different countries in the Middle East. It is common in areas where there is a desert, and there are different forms of leishmania. So, how does leishmania develop in a human? It is actually transmitted through a fly. It's called the sand fly. So the leishmania itself, it reproduces inside a female sandfly, and it will be transmitted inside to the human through blood, and it will take another form that will be reproducing within the macrophages of the human, and this macrophages at some point will will be phagocytized by immune cells, and the contents it will be releasing, leading to inflammatory reaction. And since the process itself is regenerative, it will be chronic, and the reproduction itself of the organism, the infection will be sustained, it will be persistent, and this will cause the disease presentation to be chronic. And the manifestations are different. It could be cutaneous, it could be mucocutaneous, it could be visceral. So this is the sandfly that will be transmitting the disease itself. And the Leishmania organism, it is a protozoa that carries out or is found in two forms: the promastigoid that happens that's formed within the sandfly, and then the amastigoid that's found within the body of the human. So there are different flavors of Leishmania, and it's usually named around the country that is endemic to it. And the one that is common here in the Middle East is Leishmania donovani, the one that's here, visceral. Okay. And there are three main different presentations: cutaneous, mucosal, and visceral. With visceral being like it's from the least worrisome, least debilitating disease to the most, starting with cutaneous, mucocutaneous, and visceral. And here is a small map of the entire world, and showing where is which part is more common. Like as you can see here in the Middle East, it is common to present the cutaneous and mucocutaneous form. In Southern Europe, the visceral, and in South America, the what's called especially the areas surrounding the Amazon, Brazil, Peru. These countries are famous for having mucocutaneous form of Leishmania. So, as I showed you, talked about earlier, the clinical forms of Leishmania, there's this cutaneous, the mucocutaneous, and the visceral. So the cutaneous usually presents with a painless papule at the area of the bite, as you can see here. And it will be localized, it will be raised borders and ulceration. This is due to the inability of the lesion to heal, it will form an ulcer. And there's the mucocutaneous, is the one that involves like mostly the ears and the nose. If it involves the ears, it causes the chiclero ulcer, which is well known in the South Americas. And then it will mostly involve the nose, and it will cause tissue destruction. And then there's systemic illness, Kala Azar, which is Hindi for black fever, fever called Kala and Azar being black. And then it will mostly affect children, and it will, as you see here, lead to hepatosplenomegaly and pancytopenia with fever that's chronic. The complications, cutaneous, it is mostly chronic cosmetic disfigurement because it will be chronic ulcer and it will lead to severe destruction of the skin, unless if it is treated with medications. Even if it's treated after medications, it will remain up to 1 year as a disfigured scar, which is very unfortunate, especially, and it was famous, very famous among people, Western people who were deployed during wars in the Middle East. A lot of people suffered from it. The indigenous people themselves, they suffered from it. And there's the other form, it's called the mucocutaneous. As you can see here, the septum, the palate, the the septal palate, the mouth, is here it is pierced, it is destroyed, and it will cause facial deformity. It will affect, of course, the ear, nose, throat system. It could be causing recurrent infection and all. And then there's here the visceral form, the Kala Azar. It's called the black fever. You're here having hepatosplenomegaly, which is very characteristic, like an infection that's characteristic for splenomegaly specifically is Leishmania. And it will, as you know, the results of spleen dysfunction and liver dysfunction, it is a myriad of presentations, as we recently discussed, like the hepatitis case with my colleague Hassan. The manifestations of liver will be coagulopathy, will be bile dysfunction, and estrogen excess. All will be found in visceral leishmania. It is very debilitating, and it needs immediate treatment, supportive and specific medications to treat the organism itself. So what's the first line? So this drug, it's called the stibogluconate, sodium stibogluconate. It affects the metabolism of the parasite itself. It works on the metabolism of the parasite itself. And then there's also antiminates and amphotericin. Amphotericin, well known of destroying the membranes, the cell membranes of the parasites. And pentamidine also working on the metabolical oxygen reactive oxygen species pathways and all. So this is usually the treatment, and the administration is different. If the disease is the cutaneous or mucocutaneous form, it will be intralesional. If there is what is it called? If it's a systemic, it will be given as systemic IV. And so the take-home message, in this case, cutaneous leishmaniasis, it will be a painless papule, and it will be developing into a chronic ulcer at the site of the sandfly bite. And it is usually suspected in non-healing lesions in areas, especially in desert areas in the Middle East. And diagnosis is by biopsy, skin biopsy, or skin smear by the presence of mastigoids. Forms different: cutaneous, mucocutaneous, visceral. Treatment: stibogluconates, amphotericin, antimonials. And that's it, the end.